let's go on to our next session. We've talked a bit about the need for inclusivity, and I want to hand you over now to Graham Martin, who you've previously met, who's Director of Research from this institute, about collecting good demographic and ethnicity data for improving healthcare. Graham, over to you.
Good afternoon, everyone. So the critical importance of high quality and accurate data to healthcare improvement is widely accepted. Just as you need good data for good surgery, you need good data for good improvement. Without those valid, consistently completed data, it's difficult or impossible to know whether improvement efforts are having the desired effect. But we also need to know about the characteristics of the people involved and affected by improvement efforts. If you fail to gather data on those characteristics, then you can't say for certain whether the benefits of improvement efforts are being distributed equitably. And even in some cases, they may be favouring groups that are already relatively well off and disfavouring others who are disadvantaged in the system. Equally, if you don't know about patients' preferences and priorities, which may vary according to various different demographic characteristics, then you may be in a situation where some groups' constructions of what good healthcare experience, good quality is, take precedence over others. So this session is all about examining the importance of collecting and using those demographic data in improvement efforts and other areas of health services research. We're going to focus in particular on ethnicity as a kind of a tracer issue for these challenges, but I think a lot of the things we'll talk about could also be extended to other forms of demographic variation. So the format is similar to earlier sessions. We have 3 excellent pre-recorded presentations to follow, and then a discussion to which you will be very welcome in the audience to contribute after that. Our first presentation is from Ricci Harris Melissa McLeod from the University of Otago. We'll then hear from Habib Naqvi, who is the Director of the NHS Race and Health Observatory, and then from Rohini Mathur, who is Professor of Health Data Science at Queen Mary University of London.
Tēnā koutou katoa, and hello from Aotearoa, New Zealand. My name is Ricci Harris, and I'm presenting today with my colleague Melissa McLeod. We're both Māori public health physicians and epidemiologists at the Iru Pomare Māori Health Research Centre, which is an Indigenous research centre at the University of Otago in Wellington. First of all, we'd just like to thank the organisers for the opportunity to contribute to this event. Our research focuses on Māori health and the elimination of inequities. So ethnicity data is really critical to our work. And in our presentation today, we will be focused mainly on ethnicity data in the New Zealand health sector context. And we will be speaking from a Māori and Indigenous rights perspective on why ethnicity data is such an important issue and some of the ongoing challenges that we still face around this. Just some background about New Zealand. We have a population of around 5 million people. Māori are the Indigenous peoples, making up about 17% of the population, and the majority ethnic group are New Zealand European. Historically, New Zealand was colonised by the British, with Crown governance formalised in the Treaty of Waitangi, which was signed between the British Crown and Māori in 1840. There are long-standing and significant health inequities between Māori and non-Māori in New Zealand. We have a 7.5-year gap in life expectancy and inequities across most health indicators, including health determinants, health outcomes, and health care. And we understand these inequities to be the result of colonisation and ongoing colonialism and racism, which are a breach of Māori rights. So from an Indigenous rights perspective, why does ethnicity data matter? Well, at its core, being counted is an acknowledgement of both existence and value. It means that one matters. Māori have the right to be counted and the right to identify ourselves as Māori. And Māori health advocates have long argued for high quality ethnicity data in health and population data sets as a Māori right. New Zealand's often held up as a beacon of excellence in relation to ethnicity data, and we do have a long history of counting ethnic groups with changes in definitions over time. So from earlier I would say, racist biological notions of race to more recent socially constructed concepts of ethnic affiliation, which were introduced in the 1980s and 90s, and is what we have today. So people can self-identify with the group or groups they feel they best belong to or identify with, and this applies to everyone. We do have an official government standard for ethnicity as well, and Statistics New Zealand is the government agency that is responsible for this, and it applies to all of government, including health, and it outlines the official definition, the standard question, collection processes, and classification system. In addition, there are specific protocols for the standardized collection of ethnicity and health that are in line with the statistical standard, and they've been around for nearly 20 years now. But there are still problems with ethnicity data that differentially affect ethnic groups, including Māori. So why are we still talking about ethnicity data quality? Unfortunately, in health, the quality, consistency, and completeness of ethnicity data continue to be problematic. And there's evidence that this is in large part due to the failure of the health sector to adhere to its own protocols. For Māori, there's systematic undercounting of our population in a range of health data sets, including hospitalizations, cancers, primary care, and the National Health Index, or NHI. And just to explain, the National Health Index is a person's unique health identifier. Amongst other things, it provides a person's most up-to-date ethnicity and is consistent and available across health data sets. In the context of our work recently on modelling screening interventions, we've been thinking about the importance of ethnicity data quality at two main levels. Firstly, at an aggregate population level, where ethnicity data quality impacts on the ability to estimate health and healthcare inequities accurately. And this is really important for planning, prioritisation, and monitoring the health system's responsiveness and performance to Māori health equity, as well as other ethnic groups. Ethnicity is also used to determine funding for some services. And there's also really important implications at the individual level for people requiring healthcare. In New Zealand, an individual's ethnicity is considered in the eligibility for a range of healthcare interventions, so it needs to be accurate.
So we undertook a descriptive study to examine the representation and potential undercounting of Māori in health data. And to do this, we compared the recording of Māori and non-Māori ethnicity across a range of data sets and in two key ways. The first was a population aggregate analysis, where we compared the total numbers and proportions of Māori and non-Māori on three different data sets. And the data sets are the estimated resident population, which is our official population count, the census, and primary health organisation data, which is essentially primary care enrolments. Our second analysis was an individual linked analysis, and in this we could directly compare NHI ethnicity to a 2018 census self-identified standard. For all of these analyses, Māori were defined as anyone who has their ethnicity recorded as Māori, and all other people in the dataset were considered to be non-Māori. Of the three data sets that we examined, the estimated resident population had the largest number of people and also the highest proportion of Māori at 16.7%. In comparison, primary care enrolments was smaller both in total size, but also on the proportion identified in this data set as Māori. However, using this level of data, we can't really tease out the relative contributions of differential access to care for Māori, and therefore a lower chance of getting into the PHO dataset to start with, from the other issue of potential misclassification of ethnicity and undercounting of Māori for those who do make it onto the dataset. However, we are able to examine these more closely in our individual linked analysis. So we were able to link 3.5 million individuals on the PHO dataset to the NHI and also their self-identified 2018 census ethnicity data. Within this linked PHO sample, if we use census ethnicity data, we found that 14.1% of the population were identified as Māori. This compares to only 11.9% if we instead used NHI ethnicity data. So for exactly the same cohort, using NHI as a source of ethnicity resulted in 75,000 fewer individuals being identified as Māori than on the census. This graph gives us an idea of how well ethnicity performs if we were to use it to invite Māori to targeted healthcare interventions, such as cardiovascular risk assessments or bowel screening. This analysis assumes that self-identified census ethnicity is the standard against which we compare NHI ethnicity data. And we found that of the almost 492,000 individuals who identified as Māori on the census, 78.7% were also recorded as Māori on NHI. Putting this another way, 21% or 1 in 5 of Māori on the census were not identified as Māori on NHI. You can see that there is some variation by age, with the youngest age group, those aged 0 to 4 years, have a higher match of approximately 90%, and a lower level of match in those aged 20 to 24 years, where up to 30% of Māori are missed on NHI. You can also see through the differences in the heights of the orange and blue bars on this graph that the level of match is lower for Māori males than it is for females, and this is more apparent in adults over the age of 20. So ethnicity data quality has implications for individual clinical care. The current bowel screening age range in New Zealand is 60 to 74 years, but there's been a recent extension to start bowel screening from age 50 for Māori and Pacific, which will begin later in 2022. If we were to use NHI ethnicity data to identify individuals for this targeted age extension, which I must note is the current proposed approach, we will end up missing 1 in 5 eligible Māori for the program, which is about 18,000 individuals. In addition to this, 4,200 non-eligible individuals will be invited as they will be misclassified as Māori on the National Health Index. So in summary, ethnicity data matter. Misclassification of ethnicity has real impacts on the measurements of rates and inequities, but also for the targeting of healthcare to individuals. As we've shown, there are really important variations in the levels of misclassification by both age and gender. Responsibility sits with the entire health sector in New Zealand to align with protocols and collect high-quality ethnicity data. Unfortunately, it continues to fall to Māori and Pacific researchers often to advocate and educate others on the importance of high-quality ethnicity data. The primary problem remains a lack of adherence to the protocols for collection, recording, and reporting of ethnicity data. Until now, we've largely relied upon health service providers to do the right thing. But after 20 years of the protocols being in existence, we've still not solved the problem. We suggest it might be time to rethink this approach and consider a more active monitoring of compliance with ethnicity data protocols, perhaps using incentives or consequences for non-performance. Kia ora.
The NHS is a fantastic organisation. It's perhaps the most visible social contract between people, and yet to be proud of our healthcare system is not to be blind to some of its imperfections. And what we see across our healthcare system are ethnic health inequalities that exist from neonatal health to end-of-life care, and across areas that range from mental health to genomics to cancer and diabetes, and in relation to access, experience, and outcomes. And of course, over the last 2 years, we've seen the disproportionate impact of a pandemic, COVID-19, on our diverse communities and healthcare staff. So there is a level of urgency to focus on some of those health inequalities that are outlined on this slide, for example, which are striking. And in a way, our healthcare system and our country should be well equipped to deal with that level of urgency. We have a long history of migration in this country. We therefore have large and growing ethnic minority communities. We have robust legal frameworks in the Equality Act and the Health Inequalities duties. And we've always had very good investment in healthcare research. But at the same time, it can also be argued that our country's, our healthcare system's response to tackling ethnic health inequalities has been somewhat fragmented, costly, and confused. And what we really need to do is look at some of the deep-seated issues, some of what we call the causes of the inequalities, in order to make sustainable impact on the ethnic disparities that we see. At the NHS Race and Health Observatory, we have an operating model that works upon 3 stages. And data, and good quality data, is critical for the way we work. Those 3 stages being bringing together the evidence base, if it exists, or establishing it if it doesn't exist around ethnic health inequalities, looking at that data to do so. Secondly, turning that evidence into actionable policy recommendations for change. And thirdly, to support the healthcare system to implement those policies on the ground. Now, without good quality data, we would be unable to focus on the things that we really do need to keep an eye on in order to reduce the inequalities that we see. A few months ago, we worked with the Nuffield Trust to look at ethnicity coding in English health service data sets. And through that work, we were very clearly able to see some of the issues that are inherent in trying to get good quality data at the fingertips of those that need it most. Some of the current challenges that we have include the absence of ethnicity data with regards to specific sources, such as, for example, death registrations. Secondly, the poor coverage, in particular, of ethnicity data recording across primary care. Thirdly, some of the outdated ethnicity codes that are being used at the moment within the NHS. For example, 2011 census categories as compared to 2021 census categories. And fourthly, the systematic differences in ethnicity coding between white and minority ethnic groups. But we also come across some other issues that we need to be particularly concerned about. Firstly, accurate ethnicity coding to the most granular code possible is crucial. Why? Well, because there are significant differences between ethnic groups in terms of health outcomes, in terms of experiences, and of course, in terms of accessing healthcare services. And that leads me on to the next point, which is around the other categories. And I'm tackling this one right at the end because it's something that we've come across so often within the work that we're doing within the observatory, whereas data sources very often have a recording under other Asian, other Black, other white, at higher levels. This very often for us indicates that there may well be missing data, but it is unsatisfactory because we know of the differences that exist between ethnic groups within any ethnic category. So if you look at, for example, the South Asian category or even the Asian category, we know that there are marked differences in access and in outcomes, in experience between, for example, the Bangladeshi group, the Pakistani group, and the Indian group, and within the Black group, for example, between Black Caribbean and Black African groups as well. So what needs to happen? We need to ensure that going forward, we are able to focus on the granular level of data as much as we can. And looking ahead, we need to ensure that we are focusing on improving data quality within our organizations and within the systems that hold data, collect data. This is absolutely critical for us. It's essential that we do focus upon these key areas in order to close down the gap in the health inequalities that we see, and to close down the gap in terms of the stratification that we see in outcomes in particular. This, for us, is a leadership issue. We all are leaders in this space, and we all have a role to play in closing the gap between the values that we have in, for example, our NHS constitution to close down the ethnicity gaps and the reality of our time. And of course, that reality does include the differences that we see as outlined in the earlier slide around some of the key aspects around access and experience and outcomes for our diverse communities.
Hello, everyone. My name is Rohini Mathur, and I'm a professor of health data science at Queen Mary University. Thank you very much for giving me the opportunity to talk today about the need for collecting good ethnicity data to improve healthcare. My talk has three main sections. I'll briefly describe the history and capture of ethnicity data in the UK. I'll talk about some key considerations for conducting ethnicity research and give a couple of examples which demonstrate the value of ethnicity data for tackling health inequalities. It's probably first easiest to define ethnicity by what it's not. Historically, ethnicity has been used synonymously with race, which is the belief that humankind is made up of biologically distinct subgroups. Developed in the 19th century, theories about race were used as a means to justify imperialism, eugenics, and slavery. However, the notion of race as a genetically immutable trait has been widely discredited. Ethnicity has been considered a fixed trait for a long time, but many studies now show that there is no genetic basis to the commonly used broad categories of race or ethnicity. And though current uses of ethnicity do include some aspect of genetic or biological variation, we generally focus on the wider social causes. So in the UK, ethnicity is widely accepted to reflect an individual's own self-identification, which encompasses a broad range of socially constructed characteristics. And these cover a broad range of factors, which are shown in the figure here, ranging from ancestry and migration, beliefs and behaviors, language and culture, and experiences of racism and discrimination. And the fact that these factors manifest unequally in different population groups is what we conceptualize as ethnic differences. And we know that the relationship between ethnicity and health is complex and does not always go in a single direction. Therefore, it's important when hypothesizing about and interpreting the mechanisms through which ethnicity and health are related, it's essential to be clear that health outcomes are determined by the factors that are associated with ethnicity rather than ethnicity itself. So why is it important to capture ethnicity and demographic data? Well, firstly, we want to uncover potential patterns of disadvantage and racism, which may otherwise remain hidden or insidious. And in the context of healthcare, ethnicity and related demographic data can provide a useful lens through which to identify population groups between whom disparities might exist. And currently, the UK is the only European country which collects ethnicity data in the census and across all government bodies. And this express intention differentiates the UK from other countries such as France and Germany, where ethnicity data are considered sensitive and monitoring is prohibited. In a recent review of 36 countries across Europe, the UK was only 5 countries surveyed which actually collected any ethnicity data. And the origins of our ethnicity data collection go all the way back to the Race Relations Act of 1968, which mandated the official collection of ethnic group statistics as an essential first step towards identifying and actively reducing ethnic inequalities. So I'll now move on to the second part of my talk, which is thinking about a couple of key considerations when using ethnicity in research. The first thing I want to discuss is about thinking carefully about the social context within which ethnicity is defined. So, relating to my earlier point, ethnicity classifications, that is how ethnicity is grouped in census and official statistics, and indeed in healthcare data, these reflect how particular groups have been racialized, which means how their ethnic identity has been shaped by historical and political forces. And understanding health differences between ethnic groups requires an understanding of how the political and historical context shape the wider determinants of health. So when we think about ethnicity and ethnic patterning of outcomes, we need to consider how these aspects and experiences of structural, institutional, and interpersonal racism may shape the experience of minority ethnic groups. The second thing I want to discuss is biases in the capture of ethnicity data. So in the UK healthcare system, the data that we have are primarily used to provide patient care, and our use of them for research is a secondary use, which means that the data may not be as high quality as we want it to be. And this is true for ethnicity as well as other key variables. And indeed, the recording of ethnicity is itself a marker of engagement with healthcare. People who don't have their ethnicity recorded may be systematically different from people who do, and we aren't able to identify the needs and priorities for these people and for communities who are excluded from routine healthcare data. This has important implications for inclusion in research using routinely collected healthcare data. And these concerns are particularly important in light of the recent debate around sharing healthcare data from the NHS for use by researchers. As soon as our data become unrepresentative of the population, we can no longer use them to make meaningful recommendations about how to improve care and reduce inequalities. I'd now like to move on to the third part of my talk, which is giving a couple of examples of where ethnicity recording has improved healthcare. And the first example is from East London, where we ran a childhood immunization program for measles, mumps, and rubella. And our initial work identified important ethnic differences in the rate of uptake of MMR vaccination. Using our routine data, we found that vaccination uptake was 45% lower in white children compared to South Asian children, 76% lower in Black children compared to South Asian children. And our initial work had highlighted concerns, particularly in the Somali community, related to fears around autism. And with our data, we were able to pull out the data for the Somali community separately, and we showed very striking differences and found that MMR uptake was 92% lower in Somali children than South Asian children. So this work led to focus group sessions with Somali parents to understand their concerns and identify them as a target group for intervention. And we found that after implementing the MMR vaccination program across England, Tower Hamlets had the greatest improvement and ended up with the highest rates of immunization across the country. And this was largely due to the targeted efforts identified by the focus groups and the inequalities highlighted by the data. So this is one example where using our ethnicity data helped identify groups in highest need of vaccination intervention and demonstrated the value of ethnicity recording. My second example is around COVID-19. And this pandemic has highlighted the importance of high quality ethnicity data and thrown into the spotlight how and where ethnicity data are recorded and who isn't represented in the data. So this is an example of a study I conducted with colleagues across the London School of Hygiene Tropical Medicine and opened safely in 2020. So we knew at the beginning of the study that the risks of COVID-19 infections and outcomes were disproportionately increased amongst ethnic minority groups, and that these could have been for a variety of reasons, such as living in deprived areas, working in high exposure or frontline occupations, living in large multi-generational households, and potentially a higher burden of underlying condition, as well as greater experiences of racism or discrimination and poorer access to health and community services. And by being able to use ethnicity data across an entire population of 17 million people, we were able to identify key differences in factors that may have been associated with increased COVID-19 risk. We saw that minority ethnic groups were overrepresented in highly deprived areas. We saw that South Asian and Black groups in particular were much more likely to live in large, potentially multi-generational households than white groups. And we saw that the same groups had almost double the risk of type 2 diabetes at baseline compared to the other ethnic groups. We were also lucky enough to have a sample size large enough not only to look at the 5 high-level ethnic groups of white, South Asian, Black, mixed, and other, but also of the 16 constituent ethnic groups, as shown here in this figure. And the highlighted part of the diagram here shows that people of South Asian ethnicity were at higher risk of COVID-19 mortality in the first wave. And importantly, while disparities for other groups reduced in the second wave, these widened further for the South Asian group, most strikingly in the Bangladeshi population. And here again, we have the Black ethnic groups highlighted here, and we can see in the first wave, they had a higher risk of COVID-19 mortality than white groups, but by the second wave, these differences were attenuated entirely. On a final note, I want to just make a comment about how electronic health records cannot tell us everything we need to know to understand and tackle health disparities. We need to work closely with social scientists and policy makers to make sure that the evidence is disseminated to the right groups, that it is shared with the communities who participated in the research, and ensure that we can improve the healthcare system for all. Thank you very much for listening. I'd be delighted to take any questions in the following session.
Well, thank you very much to Ricci, Melissa, Habib and Rohini for those excellent videos, plenty of complementarities between them. Unfortunately, Ricci and Melissa are unable to join us for the panel. I think Joe Whaling from New Zealand was having a very late night earlier on to join us, but it will be an extremely early morning for Ricci and Melissa in New Zealand. But I'm glad to say that we do have both Rohini and Habib here to join in the conversation. We've got a little short of half an hour for the discussion, so please do add your questions into the chat. First of all, thank you, Rohini and Habib, for excellent presentations. I certainly learned some things for them, including the welcome news that England and New Zealand are relatively good, at least at a policy level, in terms of what they stipulate should be collected around ethnicity. But there is that well-known gap between policy and practice, that sort of implementation gap. So I think as a first question, I'd like to ask you what, about your sense about why that is. What is it that means that there is that implementation gap in the first place, and what can be done to try to address it? Oh, and I should say who I'm addressing that to, shouldn't I? So let's start with Habib. Thank you.
Great, thank you, Graham. I think there are probably 2 points to highlight. Firstly, I think we need to make the best use of available data, and of course, understanding and reporting on the quality of ethnicity data in the work that's carried out at the moment, the research, etc., is important. Secondly, and looking ahead, it's important that we begin to improve the underlying quality of the data at source. And that includes within the NHS in the UK, hospital data, but also general practice data and how that's collected and recorded from patients. The second point is, what is that data then used for? And that's the practice bit, which is really important. And it's fantastic to hear all of the causes of the disparities that we hear very often around COVID-19. And we've got that from high on up from the government, etc., around multi-generational households and comorbidities and working on the front line, etc. But that doesn't look at the causes of the causes. of the inequalities. Why is that happening in the first place is a question. So we need to be more focused in terms of the use of data, and we need to also ensure that our moral compasses are pointing in the right direction if we are to have more meaningful and sustained outcomes in terms of reducing health inequalities.
Thank you. And let me put the same question to Rohini. What needs to be done?
Great, thank you. Yes, I agree with all of Habib's points, and I would perhaps like to just build on the point about having kind of better quality data at source. You know, we collect ethnicity data in a range of settings, not only in healthcare, but through the census, through other interactions with sort of government bodies. But these data are not linked up in any way. There's no way for us to bring together these valuable pieces of information from different places, you know, and ethnicity is about many things. It's about the upstream social determinants and being able to bring together ethnicity data with data on income and education, employment, housing. This allows us to get at the upstream determinants of inequalities and really make change.
Thank you. And no surprise to hear a health data scientist calling for better links between data sets. I thought it was something that came home really strongly from Ricci and Melissa's research, that, you know, the definitive gold standard census-based data, when you compare that to what's being collected routinely in healthcare, it shows that there's this huge identification gap, essentially, in terms of knowledge of who is and who isn't Maori. On that point about implementation, I think at the end, Ricci and Melissa were hinting that this is primarily a matter of practitioners, for whatever reason, presumably lack of time, lack of incentivization. There may be other reasons, failing to collect data at the point of care. I also hear your points about, you know, making use of other sources of data and using them as well as collecting them. Picking up partly on some of the examples that you gave as well, Rohini, I wonder to what extent you see this as something which needs to be addressed, perhaps in terms of monitoring and incentivization, which is what our New Zealand colleagues were suggesting in relation to healthcare staff, and to what extent it's actually a matter of trust in the system and in what is going to be done with these data, the uses they're going to be put to on the part of, you know, sometimes marginalized groups. What are your thoughts on that, Rohini?
Yeah, I think both aspects are equally important. And in, you know, much like the incentivization discussed in the New Zealand setting, we have had incentivization of ethnicity recording in the UK, and it was only for a short period of time between 2006 and 2011, but we made huge gains in the quality and completeness of ethnicity data during that time. In one of the population representative databases, completeness went from about 26% to almost 90%. So incentivization really had an astonishing effect on improving the quality and usability of these data, because all of a sudden you could make you could make research which is generalizable to the population. So I think incentivization plays an important role. We also want to make the lives of practitioners and people collecting these data as easy as possible. You know, people have good intentions to do this, but their time is so constrained. So anything we can do in terms of developing decision support tools, templates, anything that makes it, you know, just part of their routine care, go a very long way to support that. And that is something that we work very closely on in East London with the Clinical Effectiveness Group, which supports local general practices in exactly this kind of way. So that on the practitioner side, that's one thing. But I do agree that there is also establishing the importance of why we record ethnicity, why we capture these potentially sensitive looking data to patients and the public that we're asking. And I think building that trust is so important, and it's the job of us as researchers, as healthcare providers, to demonstrate or explain, you know, the benefits of recording data, of showing people that their self-identity, that their community are valuable, and we have to make their experiences visible in order to be able to target their needs appropriately. And I don't think we need to oversell it. We also need to, you know, be realistic about the potential risks. And even though they're small, we use these data with good intentions, but if bad things can happen, we need to be able to be realistic about those. And I think building trust in these data, showing that the benefits outweigh the risks, are really key to having people understand that by giving these data, they benefit society as a whole.
Thank you. Yeah, and I think that point about being honest about the risks as well as the benefits is a really important one. I think we clearly saw the risks of that in an example that I think you or someone referred to in their presentation, the care data issue, where those concerns weren't adequately addressed. And I think another thing I picked up from your comments there, I may be overinterpreting, but I think you made the very good point that it's not just patients and carers who we need to convince that these data are going to be put to good use. It's also healthcare staff, because their time is precious, and they need to see that these aren't just data collection activities for the sake of data collection, that it's going to be used to improve care and reduce inequality as well. Habib, I wonder if you have any thoughts on that point, on where the efforts might best be spent to increase data quality and data comprehensiveness.
I would absolutely agree with Rohini. The two parts to this are yes, building or rebuilding trust is absolutely critical amongst our patients and communities, and we've seen so vividly the concept of trust fast becoming a determinant of health in itself. And so that's absolutely critical that we get that right. And a lot of effort needs to be put into that. And there are a number of things that need to happen in order for that to materialize. Secondly, and with that, is the concept of making sure that we have accountability and regulation around better data recording and better data usage by organizations. I'm thinking about the healthcare organizations. So the regulators have a role to play in making sure that as part of their inspection regimes or kind of inspections that they carry out within hospitals, that they focus on good quality data as part of their scoring or their ratings. So both need to happen, and both are probably two sides of the same coin.
Thank you. I'm going to put to you a question from the audience. So this is from Jenny, who talks about research that she's been involved in, where they have found inequalities in patient experience among South Asian communities, and the audience that they've tried to put this to, policymakers, attribute that to cultural differences, expectations about what care people want, or survey design, rather than things that are rooted in genuine economic, social, political differences. This is a much broader question than the one about the data, but how do we go about addressing those kinds of dismissive attitudes, asks Jenny. Let me put that to Habib first.
So there's something here about making sure that we have representation in research, not just in terms of the topics that we look at, but also in terms of who leads the research. So at the NHS Race and Health Observatory, we have a work stream looking at exactly that. So we are working with other organizations, national organizations, to ensure that we have diversification of research at source. And we focus on these issues because we know that there are subtle cultural differences in health symptoms and in the way that symptoms are presented. We've done a lot of research on that. We know that that is the case. We know that our research tools are not always fit for purpose for the diverse communities that we have. So we need to ensure that we have good representation in researchers, and that our tools are, we need to de-bias our tools. And we need to make sure that they are representative of the diverse communities. So there's a whole lot of work that needs to be done in that specific area. But not doing that is dangerous, will lead to the widening of inequalities. And we've seen that, haven't we, in the pandemic, but we've seen that beyond the pandemic as well. Issues such as, for example, racial bias in pulse oximetry, which was one of the first pieces of work that we did within the observatory. We know that that is in part due to the fact that clinical trials are not representative in terms of participation in them, and people leading them. So that if we look at again, I'll mention it, the causes of the causes, of the inequalities, we get down to those fundamental issues that we must tackle.
Thank you. Rohini, would you like to comment on that?
Yes, I was going to say very much the same things. And I think I'd also like to build on that by saying, I think there's already a lot of positive movement in this area towards the goals that Habib has talked about. So including your target population through all stages of your research, is identified as a key priority. And NIHR have this new framework, the Include Ethnicity framework, that's what it is, where it is guidance for people designing interventions, trials, or studies about how to appropriately include diverse ethnic populations, not only in the sampling of your study, but in the design of your study and throughout. So that's a really positive change. Clinical trials now have a requirement to record ethnicity and to ensure that the trial populations are more heterogeneous. So I think we are making slow and steady progress towards this. And just picking up on the other point about, kind of the inherent bias in our clinical algorithms, these things are now being unpicked a lot. And, the ethnicity correction in the algorithms for kidney function have been removed because they systematically disadvantaged people of African ethnicity. So I think we are getting there slowly but surely.
Thank you. And let me follow up with a specific question from Josepha for you, Rohini, which is about the work that you described briefly to us in Tower Hamlets to improve childhood immunisation rates in the Somali community. Josepha would love to know a bit more about the strategies that you used there in terms of targeting that community and helping to understand and give voice to their concerns.
Thank you very much for the question. So I was just the analyst on that study. So I wasn't involved in the community outreach aspect. So my work was much more upstream in doing the analysis and identifying the groups at highest need. But we worked very closely with a local community group called Social Action for Health. And they led a lot of the outreach work. And we actually ended up doing a lot of kind of education and outreach in the mosques as well in East London, which were a great platform for us to share our resources and get buy-in into the research.
Thank you. That was an excellent answer from a co-author. I'm not sure if I'd be able to give such a detailed response for all the papers that I've been a co-author on, but I think you did your colleagues proud there. I'd like to just link the conversation back to the previous session, and we were in the green room for some of that, but we didn't catch all of it. But there were some interesting questions there around data collection in surgical research, and particularly global surgery research. So Anil Bangu, who was one of the speakers, was talking about the efforts that the collaborative network that he is involved in goes to collect data for improving surgery in both cohort studies and randomized trials. A question, or rather a challenge that he mentioned, I think spontaneously actually, was the challenge of trying to collect consistent data across very different national settings. And he used the example of ethnicity, because it's very difficult to come up with ways of coding, classifying ethnicity that work in all different national settings. And of course, we know exactly why that is. It's because ethnic inequalities in health and in healthcare outcomes are not biological in cause, the point that you made, Rohini, but they're socially, economically, politically determined. So they will be nationally specific. And now Anil mentioned the example of Nigeria, where he said there's something upwards of 200 ethnic categorizations to use. You clearly can't drag and drop from Nigeria to the UK any more than you could drag and drop the classifications that work for the UK to other national settings. So I think I'd like to ask you both that question. I think you both have interesting points on it. Habib, you made the important point around not allowing those classifications to ossify, to make sure that we're not using outdated codes from 2011 census or even earlier, so they need to develop and respond to that. I'd love to hear your views on the desirability, perhaps, of standardization internationally, or the possibility of it, or whether we should go some way towards that. And then I'd also love to hear from Rohini on, from her perspective as a health data scientist on that same issue. So, Habib, let me challenge you with that one.
It's an interesting question, Graham. And in fact, one of the first pieces of work that we did within the Race and Health Observatory was to think about terminology around race and ethnicity, because we didn't want to apply categories or labels to people from the observatory, but we wanted to actually ensure that any classifications that we use within our own organization have been agreed and determined by the public and the communities themselves. So that's why we carried out a large survey a few months ago now, with which led to very specific principles for us, and how we work, how we describe different groupings. The main point being that where possible, we do need specificity by detail so that we can best target groups, communities, in order to meet their needs. And this may well be in the context of England, it may well be in the context of the UK. But those principles are also universal. If we can apply those universally, then we will be individual countries and regions within countries, etc., will be better placed to meet the diverse needs of their diverse communities. And those communities will differ from one country to another. They will differ within a country as well. But if we stick with those principles around specificity, by detail, about making sure that we are always willing to be flexible and change with the communities that change and the way that communities want to be referred to. I think those are the most fundamental issues. So if we can stick with those principles, I believe we will be in a better place in terms of reducing inequalities rather than inadvertently increasing them, because we haven't got the right labels, the right categorization, and therefore our interventions are not fit for purpose.
Thank you. So the categories may not fit, but the principles certainly are transferable. Rohini, your thoughts on that?
Yes, absolutely agree. And I think I'm going to give the epidemiologist's answer, is that it depends on your research question. So ideally, we want to use the most granular, sophisticated ethnicity data that we have available in combination with other metrics where available, like social deprivation, any of the other metrics I mentioned that we don't actually have in healthcare data. But often, even within the UK, we sacrifice granularity for comparability. So if we want to build a body of evidence around, say, ethnic disparities, we want to compare large-scale electronic health data to smaller cohorts, right? But looking at the same thing, those smaller studies won't have enough people to look at very detailed ethnic groupings. But if they can report things at the high level, 5 categories, and we can see whether these exist in other data sets, then that comparability is worthwhile, right? So you can have less detail, but more comparability or more detail within one data set. And I think the same applies when you're looking across countries, is that if a question is looking at a more kind of biological or genetic mechanism, then it may be appropriate to use the same definition of ethnicity in different settings, because you might assume that those things are more or less consistent. But if you're looking at other factors, the healthcare setting, the social context, then you have to think much more carefully about which categories are meaningful. And there may be no way to actually establish reasonable comparisons of ethnicity because it's such a broad, heterogeneous concept.
I was just going to ask that slightly geeky methodological question about whether there is a means of almost kind of aggregating data from different countries, by ethnicity according to sort of the relative forms of marginality and challenge different ethnic groups face in different countries. Sounds like an ambitious research project. Is that something that might be possible, Rohini?
Well, so this is something that I definitely have to think about in the work that I do, because I'm very interested in looking at ethnic differences across countries and the impact of migration and social setting, and I don't have the answer yet. But I do wonder if you can sort of reverse engineer ethnicity from the other data. So I think in my presentation is about how ethnicity is sort of a basket which reflects a range of social determinants and some biological ones. And so actually ethnicity itself doesn't have any concrete meaning. It's just a way of identifying groups between which important differences exist. So if you define those groups which have differences first, and then see how they are similar, or different, then you can kind of create your categories that way. If that makes sense.
It does make sense, thank you. And it was a geeky question, but it was a very clear and lay-friendly answer, so thank you for that. A related question, I think we've got time for one, possibly two more questions. So this comes from Ibi, who talks about the interaction between ethnicity and socioeconomic status or social class, and also asks about the quality of deprivation data that are available. Again, I suppose we're thinking both about what should be available and what actually is available to healthcare practitioners and to researchers. And the question that relates to that is, you know, how, well, yeah, first of all, the question is how well those data are collected. And the second of all, again, a question I think first for you, Rohini, is about how you examine interactions between them, ensure that you're accounting for confounders, all of that kind of stuff.
Thank you for the question. So the relationship between ethnicity and deprivation is very fraught. It's very connected, very circular. You can think of deprivation as being a part of the definition of ethnicity, and you can think of deprivation as being a pathway through which ethnic differences occur. So they're really very closely connected. And in the healthcare data that I use for my research, we don't have very sophisticated measures of deprivation. What we do use mainly are area level indices like the index of multiple deprivation or the Townsend score. And these are quite useful when conducting research on a national scale because they're sort of benchmarked against the UK population. So they're useful for identifying differences within and between ethnic groups when you are modeling, you know, interactions, for example. But in areas like East London, where I work, actually, those national indices of deprivation are not very useful because East London is so much more deprived than the national average. Everybody in East London ends up in the most deprived bucket, and then you can't do anything useful with that data. So yeah, we're really lacking available data on deprivation, and I think we would love to have kind of more granular breakdowns of those indices to be able to examine the components differently, as I mentioned, income, education, employment, things about where you live, what your household quality is like. Those would be the dream.
Thank you. I'm going to sneak in one very quick final question to each of you, and it'll have to be a single sentence answer. If there is one thing that we could improve quickly and easily, almost overnight, what would it be, Habib?
Gosh, that's an interesting question. If there was one thing on my wish list, it would be ensuring that people are leading all of the people all of the time. And keeping that point in mind as they focus on research, as they focus on data, as they focus on policy and implementation. So having that inclusive approach and making sure, as I said before, keeping your moral compass pointing in the right direction.
Thank you. Rohini?
My geeky answer is going to be the one thing that would transform the work that we do is having all of the data we want all in one place, not held in different silos by different providers who have, you know, competing needs for ownership, that the data should be owned by the communities that benefit from the data.
Thank you. The health data scientist speaks again. Well, that's been a really interesting conversation. Thank you both for your videos and for participating. Thanks to Ricci and Melissa. Back over to you, Vivian.